Gayatri Ilamane. Please unmute.
Done, ma'am.
Done, ma'am.
Thank you.
Madam, recording is started. Please.
Yeah, start please. Yeah, start. Dr. Parag has joined.
I'm here. I'm here.
Yes,
Shubha.
yes. Good afternoon. Good afternoon, Parag. Yes, yes. Thank you for joining, everyone. A very warm welcome to all of you to this very emotional and very nostalgic meeting in memory of the great legend, Dr. R.P. Soonawala, sir. We are delighted that so many past presidents have been able to grace the occasion. It is indeed a very great loss that the fraternity has suffered, in particular FOGSI ICOG. There is no way that this lacuna can be filled, but it is possible to remember the great work of this legendary figure and then to have some semblance of consolation that yes, we will be able to carry forward some of his messages. So I'm very grateful to Dr. Sunita Tendulkar, the president of FOGSI 2025, and Dr. Parag Beniwale, the chairperson of ICOG 2025, for having given us this opportunity to conduct such a wonderful gathering, such a wonderful reminiscence for Dr. R.P. Soonawala. To begin with, I request the president, Dr. Sunita, to say a few words. To introduce Dr. Sunita, can I have the CV, please?
Sure. Shobha, can I say this is not the platform or a forum where a president or anyone to be introduced? I humbly request you, let's not have a introduction, dear.
All right, all right.
Thank
Let us have the few words from you, few precious words from the president. Thank you very much.
Thank you so much. First of all, thank you, dear all, for this meeting, which is much, I think wherever Dr. R.P. Soonawala is, I think he will be with us here. I don't want to take too much of a time because I know everyone wish to say a few words about him. But we all understand it's not only to the FOGSI or the ICOG where we are filling the lacunae. I think hundreds and thousands of his patients also must have felt left out. They must have felt devastated. At the age of 95, the charisma what he was carrying with him was unbelievable. I have never met such a soft-spoken, humble, any doctor or a person in my life. I was fortunate to know him in 1991-92 very closely. And I think many things which I just learned by observing him has helped me even in setting up my practice, because that is the year when I was settling as a gynecologist, a small gynecologist, entering from the medical college into the private practice. There is a huge, vast difference. And anyone who has observed or worked with Dr. R.P. Soonawala must be imbibed this quality of respect to the patient, the way he speaks with the patient, his knowledge. In those days, I still remember one incident I would like to say is, I know the film star Kajol, who has undergone ectopic surgery with him, and with the boldness he has done it open for an unruptured, and then she conceived naturally, showing his surgical skills. For me, apart from just the obstetrician of our fraternity, the great human being, the Padma Shri awardee, he was my obstetrician and he delivered my son in Jaslok Hospital. So I used to share a very different relationship with Dr. R.P. Soonawala, and I'm sure every one of you have the same feelings, and every one of you must be having he was closest to all of to you than anyone else. And that is what Dr. R.P. Soonawala was. So I think no more words will actually help me to come out with my emotions. Whatever you say for 2 minutes or 20 minutes or 2 hours, the emotions, the words cannot capture. So I'm so thankful to all of you who have joined to pay the homage to this great man. Thank you.
Yeah. Thank you. Thank you, dear Sunita, for that wonderful emotional tribute that you have placed on his memory. I am very grateful that you made time today. We know that your time is actually very, very, very limited for every program, but then we are grateful that you were able to find time. And then, as soon as I said it is for Sunawala sir, you said, of course, it cannot be
Today,
otherwise.
let it be only for Sunawala. Thank you
Yes,
so much for your
thank you.
emotions.
Thank you. Thank you. Thank you, Sunita, for being here. I shall now request Dr. Parag Beniwale to welcome the gathering once again, since this is principally an ICOG FOGSI program, and to place a few words for
Thank you.
Sumas. Yes.
On behalf of the ICOG office bearers, I welcome everyone for this program. We've been conducting the family planning webinars for last quite a few years. And I must say that Dr. Sunawala was a regular attendee. And in fact, all of us fondly remember his contributions, because every time we used to unmute him and he used to give some very nice points or tips to ponder. For me personally, when I was a managing committee member, organizing committee member at a very, very young age, when we had the AICOG Pune, that was the time I got to see him, got to know him. And any person who sees him would be in love with his personality. That was his charm, that was his charisma. And whenever we thought of starting the family planning activities this year, we could not think of starting the program without paying tribute to him, because he has given immense contribution to the field of family welfare apart from the organization. So thank you, Shobha, for thinking of this, and thank you everyone for joining, because all of us here have some anecdotes or some incidences to share. And of course, Noza, we are looking forward to your speech in the future. Thank you so much. Shobha, can we move ahead?
Yeah. I hope I am audible. I am audible. I'm having slight problem with the. Am I audible? Yeah.
Yes, ma'am.
So thank you, Parag. Thank you so much. I think it is now time to take the formal eulogy by none other than Dr. Nozer Sheriar, sir. He has been the champion of reproductive health, one of the strong proponents of free will for reproductive care by women, for women, for over the years, and many of us have been inspired from him. Just one small plan detail I would like to share is, once we have the eulogy, after that, I will request all the esteemed past presidents who have joined and the vice presidents, of course, the past ICOG chair, to pay their tributes one by one. So we shall begin with Dr. Sherrier's eulogy. Sir, to introduce you, I don't know, you have been a teacher for all of us, a guru for all of us, and we have always looked up to you for your wisdom. Please start sharing your screen and.
Thank you. No, Shobha, today it's just going to be a heartfelt talk.
Yes, sir.
So first of all, I must thank FOGSI and ICOG, and I really appreciate the fact that Sunita, Parag, Sarita, everyone's here on behalf of the organizations. And I think it says a lot to how special this person was to us. I also appreciate the fact that it is a tribute meeting and not a condolence meeting, because we are here to celebrate the life of an amazing human being, someone who's inspired so many of us. So Mimi Novik has said throughout the journey of life, we meet many people along the way. Each one has a purpose in our life. No one we meet is ever by coincidence. And for so many of us in our fraternity, in our specialty, this connection we had with Sir was unique. Each one had a personal connection when you met that man, and he really made you feel that you were the person who was so important. And I know, sir, I mean, he would often not remember names like some other very amazing senior people do, but he would connect instantly. So I'm really grateful for this opportunity to pay a tribute to this person who's been one of the most important influences in my life and the lives of so many gynecologists. Shobha, when you asked me to speak about Dr. Soonawala as a mentor, I said I will speak not just for myself, but for all the gynecologists who Sir directly or indirectly influenced and mentored. And as we shall see today, there are so many of them. I'm not going to give a CV. Everyone knows that. Spent a lifetime at Wadia Hospital. He was Professor Emeritus at Wadia and St. G.S. Medical College. He was the founder president of ISPAT, and he's one of our very beloved FOGSI presidents. We only have good memories of him. And for me, what's significant is his role in the Family Planning Association of India, which I will touch upon as a part of my tribute. I first attended a lecture by Dr. Soonawala in the main lecture theatre at St. G.S. Medical College during second MBBS over 40 years ago. His draw was so great that the hall was full to capacity. Back then, there was this person who was like someone we really admired and looked up to. And just imagine, every second MBBS student of our batch was there. We were there in full strength. And then a few years later, I had the privilege of working with him as his registrar at Wadia Maternity Hospital. He had just retired, but Wadia had this system of the consultant coming back to the same unit and working there, and he would come and operate twice a week. Here was a busy man who was looking after the celebrities and industrialists of Bombay, who made time to come to Wadia Hospital and operate twice a week on patients who needed him, but who could probably not afford the other hospitals. He could never say no to a patient. And patients would land up from all over the country, from UP, from Bihar, and he would still take care of them. This was the high point of our lives, and every minute we spent with him was an education. Now, he would be running into the theater because Sir was always running late. He was so busy. But the moment he started surgery, time stood still. And he taught us finesse. He taught us elegance. He taught us to be meticulous in every step. And he taught you to be instinctive and practical and think out of the box at the same time. We had surgeons who were very fast, very dynamic surgeons. When Sir did a surgery, he just took his time. It doesn't matter how busy his day was going to be. Above all, what shone was his kindness and fairness and the tender, loving care that he gave his patients and his staff. I've never seen him getting upset with an assistant who got in his way, with a house surgeon who made mistakes, or a nurse. I mean, we see theaters are like pressure cookers. His theater was never a pressure cooker because of his personality. Of course, his innovations remain his legacy. There is hardly an operation theater where a Soonawala speculum is not asked for while performing vaginal surgery in our country. And he had many other instruments. Some of those aren't used anymore because some of those surgeries are no longer done. He was an artist and a technician par excellence. We know that he was one of the 5 or 6 people who received the von Grafenberg Medal for his innovative copper wire device. What you don't know is he had devised a simple bottle suction evacuation apparatus in the early years of safe abortion in India. So we're talking about MVA today. He had devised this bottle. He had shown it to me once, cap on top, suction, and he would do that. And of course, you may not be aware that after the War of Independence in Bangladesh, Dr. Sunawala and a team of gynecologists went from India and performed MTPs because this was a problem they had. And for that, they used menstrual regulation. I was fortunate that he literally selected me. And when I worked with him, he introduced me to the Family Planning Association of India. And this was my introduction to the world of reproductive health and to the world of NGOs. 37 years ago, I was just a junior registrar working with him. And he just made sure he selected and said, you are going to be the person who is going to be involved with these activities, and you could never say no to him. Started with lectures. He would do a microsurgery training program, which I would assist with, and we would take lectures. We did almost some 35 or 40 training programs back then, because at that point, if ligations were done, you had to do recanalizations. The medical advisory panel of Family Planning Association has existed for over 40 years. And I can't tell you what an honor it's for me, because there have been just two chairs before me, Dr. Sunawala and Dr. Usha Krishna, and they handpicked me to be the chair now, and I've been the chair for the last 1 year. And I can't tell you what a responsibility that is. Now, very early in my practice, we traveled to an MOGS program in Dahisar. He picked me up from Bandra, and I can tell you, he drove his car at a breakneck speed. He was a very dashing, daring driver. You literally had to hold on. But he shared with me gems of how a budding gynecologist can grow in practice. He told me when to charge, when not to charge. He told me how to cope with complications. He had just been through that harrowing time when his patient, Smita Patil, had that tragedy. And he told me how he coped with it and how we should cope with it. He gave me simple tips like telling me, when you start practice, call patients to your clinic more often. Don't charge them. Give the impression that you've got a full waiting room. Call them around the same time. You know, a senior doctor doesn't need to tell a junior doctor these things, but he still did. Mrs. Wadia and he selected me to go on an IPPF regional council in Kathmandu for the first time. Ruby, my wife, had come with me. He was the most delightful and interesting person to travel with. And he would pamper you. He would take you out. We had dinners, we had conversations. And I can tell you that this person could be so many things to so many different people. As a young gynecologist, he had our back. There's one case, one of my first cases at Breach Candy Hospital. I delivered a patient vaginally. She was an IVF pregnancy, and she had a massive paravaginal hematoma, which I did vaginally. I called this man up at 4 a.m. in the morning, just telling him, this is what I've done. And he says, do you want me to come down? I said, no. And he said, what you've done is fine. Next morning, some of my other teachers pulled me up and said, you should have explored her. But he stood by me and he said, what you did is perfect. And the patient did well. So you could really just call him up at any point in time. Inadvertently, my practice did follow some of the things that he did. I used to wonder how any consultant could be seeing patients at 2 a.m. in the morning as he did, till I was doing the same thing many years ago. Every time I would tell him about my surgeries in the BRC hospital or in nursing homes in Mulund, he would tell me he had been to that same place. And to have someone that great, learning that he had to build up his practice step by step, doing things everywhere, was again something very reassuring. I was already very active in FOGSI when he became our president. And I'm telling you, I know he just came in one fine day and became president. And I really feel bad that a wonderful other person lost the election, but he brought honor and credit to the position. And there's so much that people in high positions can learn from him. His tenure was dignified. He never made it about himself, and he truly made the organization proud. He was loved by gynecologists all over the country. And anytime you went to any meeting, and the amazing thing was, even after he stopped his active practice, if you invited him for a conference of meeting, Sir was there. And he would be there, sitting there, participating. And I can tell you, he really loved the attention and adulation. I have some wonderful memories of AICOGs with Sir. I remember once in the Hyderabad conference, the event was going on, and Sir was sitting with us in the hotel, Dr. Atul Ganatra, Ritu, and me. What a lovely evening we had. He had stories about everything. He would tell you how he sat beside Dhirubhai in Dhirubhai's parties, and Dhirubhai had something to say about everyone. One very cute story that stands out is that he was called to deliver Maneka Gandhi in Delhi. The first thing Indira Gandhi told him was that, listen, you're going to the All India Institute. The doctors there will try and take over, but I don't want them to. I want you to deliver my daughter-in-law. And then he tells us how, and this picture is stuck in my head. The rod for the stirrups at the hospital wasn't locked. The screw wasn't coming right. And he's saying he did the delivery with Sanjay Gandhi holding up the rod so that the lithotomy position remained. And every time I think of that picture, it brings a smile. In my presidential year in MOGS, the one thing we did different was 9 conferences, no inaugurations. We would felicitate a past president of MOGS. The one exception was Dr. Soonawala, who was not a past president of MOGS, who was not a past president of Family Planning Association, but I believe he would have brought, and we felicitated him, and I took the presidential privilege of doing it myself. That evening, for the first time, we had the fashion show, we had the music. I know it's become kind of routine today, and we had to have a showstopper. And at that time, it was decided, and I felt that rather than one of us walking with the showstopper, Dr. Soonawala was asked to walk with this gorgeous model, Kainath Arora. And the man did it with such suave and dash and panache. And I mean, really, that's how he was. For me, the last time I heard him speak was in an inauguration of the Urja Clinic, which Dr. Usha Krishna donated to the Family Planning Association of India in Goregaon. This was less than 6 months ago. He was already ailing. He had a lot of medical issues, but that man had such clarity. And the one thing he kept reminding us was to stay true to the cause of family planning. Every time we talk about sexual and reproductive health, he was supportive, he was understanding, but he said, don't forget the core issue of family planning, because that is what the country and the world has a problem with. After that, in a FOGSI conference, I was introduced to the Maharani of Baroda in Baroda. This was the conference in Baroda in Jaideep's year. You know, the one person she inquired after, she asked me, how is Dr. Soonawala? And that was amazing for me, because whether it was Maharani of Baroda, or whether it was Muhammad Fatala, or whether it was people, the senior most people in other countries like Pakistan and Bangladesh, if you went from India, the first question you were asked is, how is our friend Dr. Soonawala? What were his qualities? I believe he was a complete gynecologist and a role model. He was an epitome of patience and compassion and empathy and kindness. Patients tell me that it could be 1 a.m., but he never was hurried. He would be giving patients time. And I always said that what he taught all of us was that you don't give just 100% to your patients, you give 110%. He was a teacher and mentor who taught us wisdom and practicality. He was someone who thought out of the box. Everything wasn't step by step. We had other surgeons who were brilliant textbook surgeons. Sir was not a textbook surgeon. And finally, he was a leader, champion, and an advocate who touched so many lives. Lives of women, lives of his students, and our lives of all of us gynecologists. So he once said, for me, it goes beyond a doctor-patient relationship. You become a friend due to the constant counseling you have to do. I thank you, ICOG. I thank the leadership of ICOG and FOGSI for giving me this chance of delivering this eulogy. Sir takes with him the blessings and the thanks of so many. And one thing I know for sure, that he is going to live on in our hearts. Thank you. Thank you, Sunita, Parag, Shobha. Thank you for this opportunity.
Thank you, sir. Thank you. What a wonderful, what a wonderful geology. And Indeed, we are blessed that a person who has known him so close as a student and then as a fellow consultant has been able to share with us. For those of us who are not from Mumbai, many of the things you told were an eye opener. And you rightly mentioned Sir's innovations in family planning. And I'm very happy that he did share an interview with the Family Welfare Committee, which I think Uday helped me with that interview and also Basab. And I think he remembers. And we had the opportunity to publish that in our committee report, yeah, in the newsletter. So that was very fortunate that Sir came out with so much of information. And as you said, he really was a genius. He was an innovator. And we must remember that when he started out, the concept of so many devices and methods was not there. And he had the foresight to think of so many new things. So we salute you, sir. And Nozar, sir, we thank you so much for bringing us so much of information and so much of insight into how his professional life was. Thank you very, very much. We were also looking forward in the form of pictures, some of your memories, but probably you will find it difficult to, I don't know, because I thought that you did have, because that is what we lacked. So thank you, sir, but for your time and your effort, it was wonderful. Can I now request Sanjay Gupte sir to share his time with Sunawala sir and what he has to say?
Thank you, Dr. Shobha. Thank you, Dr. Parag and Dr. Sunita, for having this wonderful tribute session for a legend of our time, absolutely. And so many things have already been said. But the thing to be remembered is in the whole universe, and past and present, there are very, very few people who have this, kind of life that Dr. Sonawala had, completely a blessed life, all through. And what he did for people, that's probably what reverberated in his own, sort of spirituality, if I may say so. He was spiritual as far as the patients were concerned, absolutely. And there are so many anecdotes. If I, like, Noza, if we start talking about the anecdotes, we'll go on with this session for, hours together. But couple of things I must tell you, that a lot of things that he used to very humbly, jokingly used to say. And one of the things was how an Indian Air Force plane used to come for him to go and do the antenatal checkup for Maneka Gandhi at that time, and some of the things that Dr. Nozer said. But how humble he was, I remember in when I was the president and we are having a dinner at FOGSI conference, and one of the lady doctors fell down and injured, somewhere on the forehead. And believe me, sir himself drove her to the Bridge Candy Hospital and called Dr. Tibriwala, who is the very renowned plastic surgeon, to come and suture almost at the middle of the night. Can you imagine that? And the poor guy had to, of course, come because, when Dr. Sonala calls, you don't say no at all. And he did, and probably must have done this minor surgery at middle of the night only, very, very rarely. Then second anecdote I must tell you also is, very funny, is, I when he was standing for the president, I used to go around with him on his campaign trail. He just would like to have somebody around, with him. So I was privileged enough to go with him. So once he told me that flight was at 7:30 to Chennai, and he told me, Sanjay, you stand on that main road in Dadar at 7:30 and I'll pick you up and then we'll go. I said, I was wondering, 7:30 is the flight and he's saying 7 o'clock you stand at the Dadar and I'll take you. How is that possible? But he came, he picked me up, and as Nozer said, he was always very fast driving. We went to the airport, and believe me, the Air India people at that time were actually, waiting for us, because everybody was either his patient or, everything, including the pilot, and we were actually taken straight our bags were held by these, all these great people, and we were taken directly to the plane, and then the door closed and the plane started. And you wouldn't believe, we landed up in Chennai, and we were, about to go out, and we were told that no, the road is, traffic is halted, closed, because the chief minister is coming, and that's why you have to wait. So we were waiting, and the convoy of the chief minister, then the chief minister was Jayalalitha, and the convoy came, and we were waiting there, and suddenly Jayalalitha saw sir in front of her. So she immediately came running, shook his hand, and sir, you are here when you didn't tell me that you're going to be in Chennai and all that, this. He just jokingly said, Nani, I heard, was there, I have a talk here, and your people are not allowing me to go, And he was saying it jokingly, but she took it so seriously. She immediately started yelling at all the people around her. Police commissioner, oh, you're stupid. You don't know who you're making wait. You're not recognizing he's my doctor and all that. The poor chaps, all started saying sorry ma'am, sorry sir, sorry ma'am. She said, you take him just now and wherever he wants to go. And believe me, the same convoy that she had come in, we were put in the car, and the whole convoy drove us to the, with police sirens and all, aage piche, we were, driven to the hotel. So that kind of relationship he had with, so many people and so many great people, but at the same time, as with very, 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 he was very, very down to earth, and also had full care and give everything to the patients, no matter how poor and all they were. But that's why, his life is something that we must emulate, we must celebrate. It's not time for condolence at all. It's the time for something to, that we should always keep in our mind, that something great, and that kind of personality. The biography is there, if you are all not read it, The Life Giver is a wonderful biography written about him, and I think all of us should read that, so we know what he was. And those who didn't have the privilege like us to be close to him, I think that book itself is will tell you a lot of things. So thank you, Shobha. Thank you, everyone, for being here. And I think it's a wonderful person that we are celebrating today.
Thank you so much, Dr. Sanjay Gupta, sir. It was really heartening to know more and more about Dr. Soonawala, sir, whom we have looked up to and respected for so long. I would
Yeah,
now...
Ranjana ma'am, that one about Jayalalitha was the tops. I really loved that. Because she was not a lady who could be tackled by anybody, actually.
Exactly.
So,
I'm
Ranjana
really
ma'am, please
enjoying
go ahead and
listening to
invite.
that.
Yeah.
I'm really enjoying listening to all the stories
Really,
Dr.
really.
knows
And
of
as
Dr.
Sanjay
Sanjay
Gupta
Gupta,
sir
sir.
rightly said, this is not the time to be sad.
Yeah,
It is the
yeah.
time to celebrate such a wonderful
Celebrate,
person,
definitely celebrate.
because all of us have to go one day.
Yeah.
And if we can celebrate one's life, what can be better than
What
that?
else?
Yeah,
Exactly.
yeah. Ranjana
So
ma'am, you can go ahead
yeah.
and invite Dr.
Yeah,
Uday
I would
and
now
then
like
Dr.
to
Lakshmi.
request Dr. Uday Thanewala, sir, to come and give his tribute to the legend, Dr. R.P. Soonawala.
Thank you so much, Shobha and Ranjana. It is wonderful, and I'll pick it up from where Sanjay has left. He talked about this book, Life Saver, Life Giver, and that is written by Rashmi Uday Singh, who is a very well-known writer in her own right, writing blogs and writing that column for food, etc. And even I was surprised when I read that she has written this book, because she is a patient of Soonawala, and she's written a whole autobiography on Dr. Soonawala. And if you read it, it is such a detailed description. She talks about his love for cars, fast driving, what all he did when he was taking medicine, when he was at Bardia, when he went abroad. And I'm still reading it because it's very much in detail. But that is one thing that, I mean, that itself says a lot, that a patient writes about Dr. Soonawala. So that is absolutely amazing, that Life Giver book. And what Sanjay said is very true. One must definitely go and read it. My personal interaction, I was so lucky to be at Bardia Hospital that I got a chance to assist him. I was not in his unit, but many a times I used to get a chance to assist him for various surgeries. And what Nozer has said it all, the fineness, he is one person who has taught me tissue respect. One person who has taught me tissue respect. He says, forget the time. And believe me, he was so meticulous that surgeries used to get over very fast, but he was so delicate with the tissues. And it was wonderful to watch him and assist him for surgeries at that time. He used to keep on this relation alive anyway with all of us, because when I started my practice in Vashi, which is around, what, 25, 30 kilometers from Bombay, I had one patient who was refused, who no other apparently obstetrician took on because she had a medical disorder in pregnancy. And she was staying in Vashi. And then she insisted, no, at that time, it was about 27 years back. And I just met her. Her son is 27 years old. And she told me, no, I want to be delivered at Breach Candy. I said, but I don't go to Breach Candy. I'm not attached to Breach Candy. He says, no, no, but do something. I want to be delivered only at Breach Candy because that is one, it had all the backup, and the pulmonologist she was seeing is at Breach Candy. So I called up sir, and you won't believe it. Sir booked the theater in his name, and he said, Uday, just go and operate over there. So I can never forget the favors which he does to you, because it's such a simple thing. Never, it was just wonderful. That gesture of his was great. And of course, things went well. Kurush assisted me, and I went only once to see the post-op. Kurush saw the less because I said I can't keep coming 30 kilometers for a post-op. But that was one incident which neither I can forget, neither that patient can forget, because she herself says that it was great that you could do that. But that was all thanks to Dr. Sunawala. And his struggle and his his deep empathy for patients. He has seen patients suffer and patients die because of aseptic abortions. And that is what has put him on the track, and he's devised the intrauterine device and things. It set him thinking that he needs to do something for this woman. He's described in that book tragic cases of 20-year-olds dying because of septic abortion, because in those days it was all illegal, and MTP was not it was not there. So that's how he's thought about it, and he's done so much of invention, and that's why he's one of the leaders of family planning, because he's seen the full scene, how people have suffered. It's easy to say, no MTP, no MTP, but he's seen the suffering what women have undergone. He thought of the common people. He was absolutely a gentleman and a gem of a person. In fact, Geeta Balsekar said that why don't you do a series on him, on the Diamonds Are Forever, because when I was chairperson, we have done that series on Shirodkar and Purandare and all. So that is in the offing, and we are probably going to have a Diamonds Are Forever with Dr. Sunawala. And I hope, since Parag is here and Sunita is here, they will be happy to have ICOG do this thing. So I'm working on that. Hopefully it'll see the day. So that is my tribute to Sir. I mean, when I was installed as the ICOG chairman, it was an online thing. It was COVID times, but I called up Sir, and he was there. He was there, and it was wonderful to have his blessings always, all throughout. Thank you very much for having me here, and it's great. I just love this program being happening.
Thank you so much, Dr. Uday. You have really touched the humane aspect of Dr. Uday and of Dr. Sunawala, sir. And
Very
now I would
nice.
request Dr.
No, I think Uday, when you said that he attended and he congratulated you on taking up the chair, I can really kind of see that, because Sir was so he
Shobha, in
made it.
all our ICOG webinars, sir would inadvertently join and then give his expert opinions every time he joined.
Every time.
Yeah.
I think the best witness is Dr. Lakshmi for that. So you can invite her to say.
Yeah. Dr. Lakshmi, I would like to invite you to pay your tributes.
Yes. Thank you so much, because my memories with Dr. R.K. Sonala goes back to 1987, when I was his house officer at Masina Hospital. Then I was his registrar at Breach Candy Hospital. And what everyone has said, we learned so much. I mean, for the first time in my life, I saw kill and forceps. Sir was very, very confident. Even for all VIP patients, forceps means kill and forceps. Sir would give midline episiotomy, which we never saw during our postgraduate days. And the way he used to suture those midline episiotomies, my God. I mean, it was really things to learn. And about tubal surgeries, he was very, very good at microsurgeries. And what we learned was subcutaneous closure. Way back in 1991, it was something new to us. We have never seen that subcutaneous closure. तो सर हमको सब सर्जरी देते थे, पर ही विल नेवर गिव अस स्किन क्लोजर. ही सेड देखो अंदर क्या किया किसी को कुछ समझता नहीं है, पर स्किन क्लोजर मैं तुमको कभी नहीं दूंगा. Because that is how he was. And yes, all the bad.
Yeah, I can see that. That's so
Yes, yes.
wonderful.
Never. He used to give us everything. So then it was really such a learning point. We assisted him for all his surgeries, and just a gem of a person, I must say. And when I was ICOG chair, sir was there in each and every webinar. And as you all said, when we invited him, sir, please unmute yourself, come and give your comments. He used to give fantastic comments with practical take-home messages. So I really miss him. And
Really.
I can see so many celebrities when I was in Beach Candy. So many celebrities, they used to come. And I have personally seen those celebrities, they used to come. They used to wait for him 10
नाले देखा
hours,
मैंने.
12 hours. And we
हाँ?
used to say, sir, आपकी तो मजा. All celebrities, and he had delivered so many celebrities, and we assisted him. And they used to wait for him for the OPD, in the OT. So he was a big man, a celebrity, but very, very humble, down-to-earth person.
That was the amazing thing.
Yes.
It
Yeah.
never touched him. It never
Despite
made
his
him,
greatness, his humbleness was
He will
correct.
never show off. इतना एनर्जी रहता था. हम लोग यंग थे, सर हमसे फास्ट सीढ़ी चढ़ जाते थे, ब्रीच कैंडी की, मसीना की, एंड वी यूज्ड टू से सर आप बहुत फास्ट जा. We used to literally climb 2 to 3 stairs at a time, yeah. Always smiling, and sir used to have such cute smile.
He was very tall also. I think
He
that
was
makes
very tall also. I have never
he
seen
would
him
leap.
angry. I mean, really. And he was always smiling, always encouraging.
Yeah.
Such a, I mean, gem of
I
a.
think, Lakshmi, he added great value to all your programs. That's
Yes.
what I felt.
Yes.
I was also your
No doubt.
GCM. So
No
I
doubt.
really felt very, very privileged to attend whenever he was there. Ranjana ma'am, I think we will take now Dr. Sarita Bhalera's.
Yeah, yeah.
Thank you very much. Thank you for giving me this opportunity to speak. And really, I remember, sir, not very long ago in December when we had our webinar on
Rita,
family
1 minute.
planning.
We must thank you for giving us this
No.
program to do.
So,
This is
no
your
problem.
program more
Yes.
than us. Yeah.
So I remember that we had a webinar on family planning in the first week of December, and sir had come home from the hospital. But in spite of that, he logged on. And when we asked him to speak, he spoke so clearly and with so much vision about the family planning problem in India, what we have achieved and where we have to go now. It's really, really, truly commendable. So, in his memory, I've made a very small poem which I'd like to recite. It goes, Sir, we think of you every day. When hysterectomy instruments on the trolley they lay, to FOGSI, ISPAT, and other organizations you did contribute. Your family planning work we do salute. To patients you were so kind. When colleagues called for help, you did not mind. Rest in peace, sir. Even though you are gone, your memories will always live on. Thank you.
Very good, very good.
Very nicely put, Sarita.
That is really brilliant. Very, very well written. I hope you can put it somewhere in the mail or in the ICOG WhatsApp at least, and we will be able to. Please let us.
Definitely, I'd love to. Thank you so much.
Please let us circulate it, because I don't think it should be limited only to this group. It's a lovely poem, and it brings in so much of his essence into it. Thank you so much, Sarita. And now, is Bharti there? I'm not able to see the other co-convener, Dr. Bharti Maheshwari. It is,
I saw just a glimpse
Madam
of
is
her.
there.
yeah.
Bharti Madam is there.
So abhi I will just go on to the other vice presidents who have joined. I can see Dr. Sheila Mane there, who is also the chair-elect for ICOG. So I think it's time we bring in Dr. Sheila Mane. Sheila, please. Yeah, unmute Sheila.
Yeah, good afternoon, everybody. And I thank ICOG, Sarita, as well as Shobha, Ranjana, and Bharti for conducting this program and giving me this opportunity. I think the people who have worked with Sir Sonawala have already expressed their feelings. I think as we were not in Bombay, our association was definitely not that much, but still remember the postgraduate books when we used to read about the family planning and I think Sir Sonawala's name is always imprinted as a PG, and from those days for family planning, it is imprinted in our brain. And I have always seen Sir attending all the family planning programs whenever it was conducted, as well as the ICOG webinars and his interaction. So, salute to him, and I think we were fortunate to have such seniors who could. Show us the way and the path, and we can really look towards them to see that if we can do a little bit of that in our life or in our fraternity, as well as whatever we can do for the society, if we can pick up some points, at least that much we can do. So once again, I say thank you and my tribute to Sir Sonawala. Thank you.
Thank you, Sheila. I think Dr. Archana Baser was his student. Archana was sharing something on the chat box, and I said that I will take her in. Dr. Archana, are you there?
No, Madam is not there.
No.
But I did see her. I did see her message. Okay. Okay, so now let us see if anyone else wishes to speak for him. And that will be great if anybody else wants to pay their tribute. Yeah.
Till people are gathering their thoughts, one more funny thing I'll tell you about Sir is he used to be extremely fond of chocolates, and we were at Kuala Lumpur conference, of FIGO, and he had bought so many chocolates, like in kilos, absolutely, and we were wondering. So that was the only purchase that actually he made, and then I followed with him, and then I found out that his breech candy lockers used to be always full of chocolates, and everyone in between, various surgeries, Sir himself used to go and have the chocolates, and he was very, very fond of his chocolates, and such a wonderful, he had such a presence at the time of our conference, and when I was a president, I'd created a think tank, and Sir was the chairman of the think tank, and he selected people from all the fields, including among this Dilip, Padgavkar, who was Times chairman, and from various fields, from that time, the IT experts and all, and we had good sort of connect with all these people, giving us the ideas about what can be done in gynec and obstetrics. I wish somebody starts that think tank idea, again for FOGSI, which will really widen our, vision of FOGSI.
Yeah, he always used to say that we must never stop thinking about what more can be done, because there is always scope and for new thoughts and ideas. So I think that holds good for him. That is so good.
Absolutely.
Yeah, absolutely, sir. Absolutely. So I had actually I was looking forward to other past presidents. It looks like there are other commitments today, but I do believe that everyone who has worked in FOGSI has a very strong connect with Dr. Sunawala sir's memory, and we all have learned from him what it is to have a high value of practice of acquiring knowledge and of disseminating knowledge in obstetrics and gynecology. We take with us all his teachings and we remember him. Indeed, he has become a legend for us. And I must say that very few will reach uh, that stage or will reach that level where people will remember them for centuries. And he is such a person indeed. Um, I think I can see Archana now. Is she joined? No? Okay. All right.
Archana,
You are mute, Uday.
Dr.
Unmute.
Uday, you're muted.
yeah, sorry. Archana had put a very nice comment in the chat box. He must have come and she must have written this. And that is what
Correct.
even I remember.
Hmm.
Used to do a laparoscopy in the OT, then we used to come out, and in the room he used to write in his own diary what the findings were. Because remember, those days he had to know exactly where the tube is blocked, what are the adhesions, so that he can plan the tuboplasty. And he was so meticulous about the notes of the patients. He used to maintain it in his own diary, which rarely any honorary would do in Vadia because it was left to the residents, to write the notes and write the operative notes. But he was very, very particular about his patients. And that is what it is, people, the patients need realize that the doctor is connecting with them. He was an
Correct.
amazing person.
No doubt.
So much to learn. Yeah, I have also found that there will be a lot of finer details which gets missed out if the person who has operated does not write the notes. I have also found that when I do check my residents' notes the next day. So I think what sir was trying to tell all of us, that is what even I'm remembering the Prime Minister also at this time, because he would also say instead of telling others to come early, you must walk in early yourself. So that is how he tried to give us so many messages through his life. So his life itself was a very huge message. I must say that he championed the cause of family planning, and he did say that it was everyone's duty to propagate it, not only the doctors, not only the gynecologists. So it should be adopted as a culture, and it must be brought into conversation as much as possible. So people look at it as a way of life, and they have the concept of reproductive planning, very initial stages of their married lives, so that the nation always benefits when responsible citizens are there. So I can see Dr. Parag again there. So Parag, this is where we are now. Hello.
Yes, right.
Yeah. So quite a few messages we got, and it was emotional and it was enjoyable. And Dr. actually, Dr. Sanjay's inputs were some of it was very hilarious.
And
Also,
Dr.
we really
Noser
enjoyed.
and Dr. Noser's also.
Dr. Noser gave a wonderful
Yeah.
eulogy. Yeah. So nothing short of a very detailed tribute to sir.
Yeah.
So that was I feel that we have done some justice to his memory today. Of course, we cannot light a candle in front of the sun, but we can make an attempt to pray that more such legends are born, and they are born and they become obstetricians and gynecologists, so that our fraternity gets enriched. So thank you, Parag, for that wonderful opportunity given to all three of us, to Ranjana ma'am, Bharti, and myself. And we really enjoyed doing this segment. Thank you so much.
Thank you, Shobha. Thank you, Parag. Thanks.
Yeah,
Thank you,
thank you.
Parag, Shubha, Ranjana.
Thank you,
Yes,
everyone,
thank you
for
very much.
joining. Thanks a lot for your inputs.
Thank you.
Thank you. Thank you all.
Thank you, Sanjay Gupta sir. Thank you. And we now have very nice panel discussion and a quiz coming up, because Sunavala sir would have always wanted an academic session. He would not have wanted us only to pay respects to him. He would have also wanted us to deal with family planning situations and would have wanted us to impart knowledge today. So that is the reason we felt that we must keep this panel discussion. And to introduce the moderators, can we have the CVs, please? Is Bharti there? Then she could have taken over now. So it's my privilege to introduce Dr.
I
Professor.
think, good evening, everyone. I think we can skip this.
Okay, I'll
CV.
just mention the names
We
then.
get more time to discuss.
Definitely, Seema.
Yeah.
Seema, so Dr. Seema Hakim, just put the slide back. Just one designation I need to read out. Professor Seema Hakim from the Department of OB-GYN, JN Medical College, AMU, Aligarh. Recently retired, of course, but then, we always remember her as a very assiduous teacher. Next, please.
A wonderful teacher.
Wonderful teacher. Dr. Radhika Chetan, the young prodigy from Bangalore, and very good in this subject. And she was really a champion for my committee. So Radhika is there, associate professor from BMRIC. The panelists are very dear friends, of course. Dr. Vinita Singh from Patna, from NMCH, associate professor. Bharti Abhyankar from no, I'm not getting the designation. I'm sorry.
Consultant, Purva Hospital, Kolhapur.
Okay, yes, I got it. Yes, thank you. Thank you, Ranjana ma'am. Next, please. Welcome, Bharti. And of course, a very dear friend, Geeta Medirata from Delhi, from Sri Gangaram's Hospital. And this is another young prodigy from the state of Karnataka, from Bidar. And I'm so very proud of this girl, Arati Raghu. She does a lot of work in the field, and I welcome you, Arati. So here goes. The stage is all yours, Dr. Seema and
Jyoti
Radhika.
Guha.
Yes, and of course, oh my God, how can I forget Dr. Vishwajyoti Guha, senior consultant, Manipal Hospital, Mukundapur, and of course, Bhagirathi Neosia, Women and Children Center, Newtown, all the way from Kolkata, actually. Thank you for joining, Vishwajit. So the stage is all yours. Yes, please. You can share your presentation and you can start. Thank you.
Thank you. Thank you very much for giving us this opportunity. To start with, I think, Radhika, you may start with a few introductory slides, and then we can go on to those cases which are
Sure,
being
ma'am.
presented by you.
Ma'am, you're able to see the slides?
Yeah.
Yeah.
Okay. So good evening, everyone. And it was actually a privilege to be part of the CME, which is being done in remembrance of Sonawala sir. And I thank Shobha Gudi ma'am and even all my co-moderator and all the panelists also. And let's start with the panel. And we already know this is just a basic introduction. We know about the cafeteria approach. We are going to offer all the choices to the women, but we should also know about the tailored approach where we can give some options based upon the patient's medical conditions. So here, this panel is basically about the tailored approach where patient can have some non-communicable disease or some high risk factor. Because of that, she is going to have a limited choices. So this is what we are going to discuss about. And the panel is being done in moderation, in line with the WHO guideline, World Health Organization. But of course, we can discuss even the good clinical practice guidelines, whatever the panelists are following in their practice, that also can be discussed. And we already know the WHO medical eligibility criteria, which is category 1, 2, 3, 4. So generally, category 1 and 2 are preferred for use, and category 3 and 4, whichever contraception method comes in category 3 and 4, are not being used. And similar categories are even for the female sterilization, where we can accept the patient if the patient has got certain conditions, but we have to exert some caution, like obesity or previous some medical disorders there. We have to exercise some caution when we are performing sterilization, or we may have to postpone the surgery due to some condition like LRI, respiratory tract infection is there like this. So we are doing this panel in line with the WHO criteria. So this is the WHO MBC wheel. It also comes under as a app. we can use an app both in the iPhone and also the Android users can use the app, and we can utilize it whenever we are screening and counseling the patients for the family planning methods. So, ma'am, I request you to please take over and start with the first case.
That brief introduction, our first problem is a 29-year-old para 1 live 1 who delivered just 6 weeks back. She has a history of GDM. Postnatally, metformin was continued on her, and her BMI is also on the higher side. It is 29, and she wants contraception, and she has come to you. But before I ask this question, Dr. Vinita, what went wrong in this case? Let us discuss what went wrong that she herself has to come and ask for a contraceptive device. Yeah. Am I audible?
Yes, ma'am.
Yeah. So Dr. Vinita, I hope you're there. So my question to you, before you advise her contraceptive device, what went wrong in this case? That she has to come and ask you for a contraception after 6 weeks of her delivery.
Ma'am, Vinita ma'am, are you there?
If she is not there, any other panelist
yeah.
can take up this question.
She should have been counseled right at the time of discharge that she must follow some form of contraceptive in future. So that she was not aware on what not counseled, and that's why she has to come.
I think giving a contraceptive advice in antenatal period, it is a part and parcel of this antenatal care that it should have been given to her. Then maybe in due course of time, she is willing to modify. Like if this case would have been given a counseling about PPIUCD. So that maybe that would have been inserted then and there, and then she doesn't have to come and ask you for advice. So thank you very much. And what advice would you like to give her? Now that it has not been given to her, now what advice?
Now we have to explain her the risk factors about her future pregnancy. If she conceives immediately, she is already a case of GDM, her BMI is on higher side, and the baby is just 6 weeks old. So we have to tell her each and every aspect if she gets pregnant, what will happen. So she must follow, as she has come on her own for contraceptive advice, definitely. She is aware about everything. So we should offer her various contraceptive choices and what are suitable for her. We should not go on telling her each and every method of contraception that is there, but which contraceptive method is suitable for her, that we should tell her. And then after discussing with her, we have to give her a choice and advice regarding that contraception.
Dr. Bharti, do you think IUCD will be a good method for her if she chooses one? And will it make a difference if she has a normal vaginal delivery or if she has a cesarean section for eclampsia?
Yeah, definitely IUCD is a good option. Only thing is she's a GDM, not DM. We have not proved that she is continuing with, but she is on metformin. Maybe her sugar levels are high still. So we have to advise her to avoid the infections. The only danger to her is if we insert the IUCD, the chances of infection are there. If we take care of that, then IUCD is the best choice for her. Of course, if the delivery is vaginal, then that is also good choice. And PPIUCD, again, it's a controversial, madam, because many don't like to use this PPIUCD method, patients also and clinicians also.
I think at this point of time, can we have an opinion of expert about PPIUCD? Because if Dr. Bharti is saying that it is controversial, I would like to have a comment from the expert. So Dr. Shobha, will you? Dr. Shobha Goody, I hope she is there.
I am very much there. I won't leave.
Yeah, please.
I won't leave. This discussion is very important for me.
We need more clarity from you about PPI.
No, what Bharti says is both true and false. Both aspects are there. What she is saying is true about private practitioners, that private practitioners don't like PPI UCD. Patients also, what she says is true, that patients don't like. But what is not correct is why they don't like it. They do not like it because it is not understood as a scientific method, whereas we all know that it is a highly scientific intervention. It is a proven intervention. Only thing is it requires intervention into the uterus at the time of delivery, which people feel that the system should be clean when the woman goes home, and this interferes with that concept. They feel that something is remaining behind, which is not correct. So if we tell them that this is medicinal and it is the same as taking antibiotics or taking painkillers, instead you are having a IUCD, so it is a medicinal intervention, and it is a contraception which is concurrent, and she goes home with the contraception in the uterus, and she's protected from any pregnancy. So I feel that there is not enough conversation about it, and the conviction for private practitioners will come if there are some training programs, and the conviction will come if they start inserting and they start offering. Dr. Seema, especially with the higher rate of cesareans which we are seeing, if there can be a concurrent LARC method along with the cesarean, much of the damage will be offset because the woman doesn't conceive for more than 3-4 years. So I feel it is a very strong method, and huge advantage that it can be given at the time of delivery. That means you are providing it to so many patients at any given point of time.
Okay,
It's
so
a
with
very
a good
good method.
counseling, with a good counseling, we can
Yes,
give them PPIUCD, and GDM is not
absolutely.
a
Yeah.
contraindication.
Yeah. And I am sure
Thank you.
that in
Yeah.
due course, Bharti will become a believer in PPIUCD also.
Certainly, certainly. So, Radhika, you prepared some answer to this question. Just, according to WHO criteria, with history of diabetes, of course, at 6 weeks, we can give her progesterone only pill, or we can apply copper T on her.
Yes.
Dr. Shobha, I would like you to answer one more question. If the opportunity of PPIUCD was missed in this case, and if she has undergone cesarean section, so at what time that copper T can be applied post cesarean section? Why am I asking you this question? Because when we were many years ago, when we were doing our post graduation and training part, so we were told that if she has undergone cesarean section, you will have to wait for 3 months that before you can apply copper T, and
Yeah.
6 weeks if she has normal vaginal delivery. But these days, now after normal vaginal delivery, they said that even after 4 weeks you can apply. But for cesarean section, it has not been specified. So I would like you to make this point clear, especially for postgraduate students and for many practitioners
Yeah,
also.
thank you. Thank you, Seema. I think Radhika also knows very, very well the answer to this question.
Yes,
The
ma'am.
4 weeks insertion is very valid after cesarean section. So it is the same as normal delivery and cesarean for 4 weeks and immediate post placental. So when we talk about postpartum IUCD, it can be immediate post placental, it can be within 48 hours, and it
48
can
hours.
be 4
After 4
weeks.
weeks.
So
After 4
after
weeks is
vaginal birth, the all three timings will apply. Like immediate post placental, or if she is in the ward, you bring her back and you insert her and then discharge her on the second, third day, or call her after 4 weeks. When she has undergone a cesarean section, it can be immediate post intra-cesarean. We call it intra-cesarean IUCD. We don't call it post-placental, it's intra-cesarean. Or it can be after 4 weeks. The 48 hours one does not exist for cesarean section because it's immediate postpartum, post-operative. So it is either intra-cesarean or it is 4 weeks. So
4
4
weeks.
weeks is very, very much feasible and indicated for PPI-UCD. So that is there. In Government of India also says the same thing.
Can I come in? Thank you very much. We can go on to the next problem now, Radhika.
Yes, ma'am. 29-year-old, Paravan living one. She had MTP by medical method of abortion 1 month back. Okay, she had a bleeding and she was examined by her physician and she was told that she has complete abortion. But after that, she has not resumed her periods. And the first child is 2 years, but she wants contraception for 1 more year till the child becomes 3 years. So, and she asked for an advice. Bharti ma'am? Dr. Bharti? Can I request any other panelists to
Can I ask
take this
Vishnu
question?
Jyoti? Can I ask Dr. Vishnu Jyoti?
Yes, thank you, madam. So first of all, let me just go back to the previous one, that IUCD one, because I wanted to just bring out a very important point out there is that whenever we insert PPI-UCDs, what happens is that counseling is not done properly. And that is the reason why most of them will come to you after 6 weeks or 8 weeks or after, say, 3 months and want that IUCD to be out. And that I have faced in my private practice. I usually counsel them again and let them go back. And very few people do return. So that is one point that I wanted to just take along with this. And regarding this patient that you have here, she's just had a medical termination and had taken medical pills for medical termination of pregnancy, and she has now resumed the periods and she wants to contraception. Now, for her, I think any contraception is of. We usually use a make checklist, but I think for her, any sort of hormonal contraceptions is absolutely fine, and she
Yes.
can have one. And of course, you can give her an LNG IUS if she can afford one, or if we can give one. IUCDs is there, but for her, I think MHC will be one that we can usually go by.
Yes, sir. She is definitely fit for contraceptive method, whichever she wants. She can have the cafeteria approach also. But only thing is because she has not resumed her menses yet.
You
There
must
can
have
be
a pregnancy test.
unprotected sexual intercourse. So we may have to ask her whether she has got any history of unprotected sexual intercourse in this last 1 month after her abortion. So that has to be checked. If there is no history of unprotected sexual intercourse, we can go ahead and insert or give whatever method she wants to. Yes, sir. Seema ma'am? So just I wanted to add one point to sir, whatever sir said. PPI-UCD, the main reason for anxiety among clinicians and among the patients is thread is not being seen. So when we insert the PPI-UCD in the medical colleges, we put it very liberally. But once they go out for follow-up in their respective centers, once they say that thread is not seen, both clinician and patients, everybody become very anxious. That is the main reason why they want removal. They don't have any other complaints, but they come for removal because thread is not being seen.
And another thing, Dr.
So that is
Radhika,
the
what
main
happens is,
reason for.
Another thing, Dr. Radhika, what happens is whenever they are inserted that PPI-UCD during cesarean sections, our postgraduate trainees hardly counsel them. And even some of them,
True,
I have
sir.
heard when they come, they say, we have not been mentioned about something being put inside my uterus. So that is somewhere we lack in our counseling aspect. And I think the postgraduates need to learn that whenever you go and intervene on anything, you must ask the patient's
True,
consent.
sir. Counseling is the cornerstone for contraceptive methods. True,
Yeah.
sir.
So
Ma'am.
now the message has gone very clear and loud that counseling part is very important for PPI-UCD. Moving ahead, a 30-year-old para one live one. She delivered 6 weeks back, breastfeeding, not resumed her periods. Of course, just 6 weeks back that she delivered. She gives history of eclampsia, and and she's on regular follow-up. Now her blood pressure is 130/80 on antihypertensive, tablet Nicardia 10 milligram twice a day. And now she seeks contraception for spacing. So, Dr. Geeta, what contraceptive advice would you like to give her?
Thank you, Dr. Seema, for that question. And thank you, Dr. Shobha, ma'am, for giving me this opportunity. So here, since she is a case of eclampsia, and she's 6 weeks postpartum, probably breastfeeding, and her BP is well controlled. That is the important thing to note. And she has one baby, 30-year-old. So, as per the WHO criteria, the MEC 1 and 2 would be, we can give the progesterone only pills. They are quite safe. Or if she opts for implants or IUCD or LNG IUCD, can you hear me? Hello, can you hear me?
Yes,
Yeah,
ma'am.
yeah,
Voice
we
was
can.
breaking.
So,
We can hear you, ma'am.
but coming to the oral contraceptives, etc., the pills, the patches, and the rings are an MEC3 criteria for such a case. And we have to also remember that now she's an educated girl. She's told you her blood pressure. She's well controlled. So these medicines are quite safe for her. However, if we cannot evaluate, we cannot be sure of her BP is very high, then in those cases, the progestin only injectables would become a contra, like a DMPA, NETN, etc., would become a MEC class 3. Hello, can you hear me?
Yes.
Hanji. So this is what my brief message is, that well-controlled BP, we can go for the progesterone-only pills or injectables or IUCDs. However, to avoid the combined oral contraceptive pills in these cases, and even monthly injections, the pills, the patches, and the rings also should be avoided. And if I have permission, Dr. Seema, can I comment on the previous case where the patient has not had periods?
Yes, sure,
After the medical abortion, we have to rule out, a retained product or some, problem, or she may have conceived. So I think this point was very well brought up by the speaker, that we have to again rule out a fresh pregnancy before, and also rule out an incomplete abortion.
Yes.
Thank you, Dr. Seema.
Very true. Dr. Geeta, for answering it so beautifully, especially eclampsia, pre-eclampsia, it is so common, and a large number of patients, they will be needing contraceptive advice, and you have really explained everything, all those which can be given to her. Thank you very much for that question. And we can go on to the next problem. Radhika?
So here is a fourth case. 26-year-old. She is para 2 living to abortion 1. She has undergone molar pregnancy evacuation 1 week back. She has undergone suction evacuation, and it was a low risk molar pregnancy. Histopathology also has come as complete mole. There is no history suggestive of, there is no examination suggestive of choriocarcinoma also. And beta HCG is currently 23,000. It is declining. Earlier it was around 50, 60,000. Now it is declining. So can we offer any method of contraception for her? Aarti ma'am?
Yeah, definitely, ma'am. She needs contraception. And for post-molar pregnancy, we usually follow them up with serial beta HCG monitoring till they become negative. And after 6 months also, we have to continue monitoring with the beta HCG. And till their level are 6 months after the total zero levels, we have to give them contraception. She should not become pregnant. And for that, I think combined OC pills, even progesterone only pills, progesterone injections, implants, they work well. We have to counsel regarding not to discontinue in between. About IUCDs, sometimes they cause intermenstrual bleedings, and because of that there may be anxiety with the post-molar pregnancy. That is why we should not use that, but other combined and only progesterone contraceptions we can give them. And already she is para 2 living tube, even we can offer sterilization also for her.
Thank you, ma'am. So earlier there was a motion.
Can I ask Dr. Aarti if
yes, ma'am,
sterilization? She has just show me the case again, Radhika.
Yeah, she just have
Well,
evacuation 1 week back, so we
yeah,
can postpone it for now, but
yeah.
definitely she can.
At least,
Yeah,
yeah. Let everything come back to normal, and I think by
correct.
that we should wait, not
Yes,
be
ma'am.
in a hurry to do digestion.
Yes, ma'am. So the only thing what I was concerned generally was earlier we always thought after molar pregnancy evacuation we only give condom as the contraception. We
Yes.
thought till the beta HCG came down to 0, we should never prescribe hormonal method of contraception. It may increase the risk of persistent GTD, but however, 2009 CDC and WHO has included all the hormonal methods of contraception as category 1. So we can use hormonal methods of contraception. We need not wait for the beta HCG to come down to 0 level. So that is the message we wanted to give
Yeah,
you.
that is good. That's a good message, Radhika.
Thank you,
And
ma'am.
I just wanted to add about the devices because the uterus will be very soft,
So,
right? And it may take slightly longer to involute, etc. So it will be better to avoid the intrauterine devices. Hormonal methods have the added advantage, you will all agree with me that they do prevent a woman from becoming anemic. And if she is anemic due to molar, it will help in better recovery actually, because they all reduce the blood loss,
yes,
whereas IUCD can do the reverse. So that is the reason. And also, putting in a device can cause other types of bleeding. There should never be any confusion about the menstrual bleeding or the intermittent bleeding which she has. So, when cannot be confused about the symptomatology. All in all, I think hormonal contraceptives are very suitable. So that was well brought out by Aarti also and Radhika also. It was very nice. Yes.
Thank you,
thank you,
ma'am.
ma'am. So we'll move ahead with the next case.
So she's a 28-year-old para 1 live 1 delivered 6 months back. She was following lactational amenorrhea method. As menses returned 2 days back, she has come to hospital seeking contraceptive advice. And she gives history of epilepsy, well controlled on carbamazepine. Last conversion was 2 years back. So, Biswajit, what advice should we give her?
So as we can see that she had a convulsion just last convulsion 2 years back, and she is well controlled with carbamazepine. So I would not I would not just try to change over to another drug which is a less liver in the inducer, but continue with the carbamazepine. But at the same time, we know that it is a liver enzyme inducer, and any sort of hormonal contraception will not work for her. So we can actually give her DMPA preparations, which are injectable hormonal preparations, and of course the LNG IUS is there, and IUCDs in the form of copper IUCDs will be useful. And regarding combined injectable contraceptive, we know it's a MEC2 criteria, so it's better not to use it if we can. But if she is unwilling to have a IUCD inserted or unwilling to have a DMPA, then that is one of the things that we can look for.
Biswajit, may I ask you one question? That combined injectable contraceptive, is it very popular in our
No,
country?
it's not. It's not popular at all
Not available and not popular
It
in
is
our
not available. It is not
not available.
available.
Yeah.
So the best and the other thing, of course, if she wants a combined oral contraceptive, that is something that we will not prefer her to have, because carbamazepine is a liver enzyme inducer. Now, on the other hand, if we can change her to something like levetiracetam or lamotrigine, there the liver enzyme inducing capability comes down much less. In that case, maybe POP is useful and progesterone only pill can be used, but of course, we have to explain to her the side effects of it.
Correct. Can I add a point here, Seema and
Yes,
other panelists?
sure.
Yeah, Seema
Yeah.
and our Radhika. See, the thing is, anti-epileptics, whenever you speak to neurophysicians, they will say that epilepsy is a progressive disease. In some it progresses fast. More often it is a very indolent, very slowly progressive. And of course, with the current treatment, many of the epileptic women are doing extremely well. I think we have all had that experience, especially with levetiracetam. Of course, that is true. But even then, see, they'll be taking medication every day. and putting them on again, oral pills.
Oral.
Right. If they forget, then that becomes a problem. So if at all we are considering for them, even with other anticonvulsants, I'm telling, not with the usual ones where CHC cannot be given. So what I feel for such women is if you can remove that element of user dependence and put them on LARC methods, which will it not be more suitable for them, right? If we
Definitely.
can put them on to implants, we can put them on to, because these methods do well for them. And the only one which is not very well researched is the implant with the usual anticonvulsants. But even when you go into the implant MEC criteria, they say that it can be given.
Exactly.
So I think that it's better to promote LARC methods in women who have epilepsy, because at least then that worry about taking the pill every day, about missing the pill and becoming pregnant, etc., is done away with, and they benefit. And they are in better health, I feel, with LARC. So, yeah, so just remember. And
Dr.
meanwhile,
Shobha, mhm.
huh, yeah,
Sorry.
Geeta, yeah,
Anit,
tell me.
I was just going to share a personal experience which happened quite recently. Patient epileptic delivered her, I think, 2 cesareans. I only did, and then finally she says we don't want. So I said, let us put a levonorgestrel IUCD in my OPD. Very well controlled last, and she is one of those cases of epilepsy, very very frequent epileptic episodes, not very well controlled, I should say. And husband was very keen that we don't want any child, for obvious reasons, because of this. And you won't believe the horror story which I'm going to tell you. I told her, you come to my OPD, have your food, come. I put it in my evening OPD. And can you believe it? She just got up from the examination table, sat on the chair, and just gave a scream and fell on the floor. It was so horrifying. I thought I'll just share it with all of you. It was
She got
really
a fit, you
horrifying.
said?
Yes,
She got a
yes.
convulsion.
So
Yeah.
she was one of those rare cases of, not a very well controlled one, but very
Correct,
keen
correct.
due to
Procedures
husband
are
that
always dicey when they are
yes,
having an
yes.
unstable
So,
epilepsy. Yeah.
so especially,
So
when you're putting
probably, yeah, that's a
implants and
very good case
IUCD.
you shared. Yeah.
So I then learned my lesson that for such cases, I'm going to take them to OT and put it,
Yes.
even though
Yeah.
it was the previous
Yeah.
2 cesarean, and
Exactly.
I was
Correct,
bold
correct.
enough to
And
put it in the OPD because it was a nice, antiverted uterus. I could
I know.
sound it and put it. But what I said
Correct.
is sometimes chivalry should not be shown like this. And
Yes,
just I'm
yes.
teaching from my own experience.
Absolutely. And thank you for sharing, because I just wanted to bring that fact up, that though we consider intrauterine insertions and implant insertions as outpatient procedures,
Yes,
Government of India does
absolutely.
not even mandate a consent. But as practitioners, we
Correct.
have to be very cautious. We have to be very, especially when there are medical disorders. And maybe if
Yes.
it is an unstable disorder, better to take a medical opinion
Hmm.
that I am subjecting the patient to this. Do you want any extra cover for the procedure? And if
Absolutely.
anesthesia is needed, to do it in the OT. But never
Mm-hmm.
deny her the contraception that she is seeking for.
Mm-hmm.
So that is the message that
Yes.
Geeta wanted to give, probably, and I'm so happy to join her in giving it. Thank you so much.
Dr. Shobha,
Thank
there is one question in the chat
Yeah,
box,
we
and that
have
is
to
a
take
very
that.
relevant.
Yes, yes, yes.
Yeah,
Please
very
take that
relevant.
question.
Property versus LNG IUS. If there is no AUB, should you?
उसके भी पहले एक है, उसके भी पहले एक है,
Yes,
उसको भी ले
I
लीजिए.
think those questions are very relevant also.
Deepika Logane has asked. Yeah,
Yeah.
correct. So, Radhika, the first question is that, thread not seen. First, you tell what you do in Manivilas Hospital for such cases. Then
Ma'am,
I will
yes.
speak.
So
Yeah.
earlier, before the age of ultrasound was not easily available everywhere, we insisted that patient to feel the thread and confirm that it is in situ. So nowadays that instruction it should not be given at all. Patient should never be told to feel for the thread and confirm and all that. And everyone needs to be trained. It doesn't matter even though thread is not seen. Most of the time, yes, by 6 to 8 weeks, it does descend. The thread does descend, but it doesn't matter. It doesn't cause much of a problem while removing. Okay, most of the time it is embedded in the cervical canal, ma'am. So we just have to, rarely we may have to do some dilatation. dilatation and then remove the thread with an artery forceps. But generally, even if you just with the artery forceps or with the dilator, if you poke the cervical canal, you will be able to get the thread. For removal, it is not at all difficult. So very rarely it happens that we have removed under ultrasound guidance. But most of the time, removal actually does not it's not actually difficult.
Correct. So for the very firm message to all practitioners is that don't make threads a big issue in PPIUCD. It is not, it is a non-issue. And the patient also should understand it like that. It's a non-issue. Whenever they are in, whenever they are concerned, we can do a POCUS, a point of care ultrasound, which most gynecologists, almost 99%, we are able to do that and show them the device in the uterus. That is one thing. The other thing is to understand ourselves as to what happens to the thread. Then we will not feel so kind of, so kind of out of sync that we must see the thread, we must see the thread. So the thread usually in the process of involution, it gets treated by the cervical mucus in such a way that it kind of coils up and it doesn't have the same stiffness as an interval IUCD, which always remains outside the os. Now, this thread of PPIUCD, because it has gone through that reproductive change of involution, it becomes a little softer and gets curled into the cervix. Now, the recommendation is very clear that if the thread comes out at the follow-up visit, you just have to trim it. The correct direction given is to trim it. One should not pull, one should not check, one should not look for whether it is descending or not. You should just trim it in the usual way, leaving about 1.5 to 2 centimeters outside the external os. That's all that is needed. Very often it gets curled in the posterior fornix also. And if it is affecting the partner, then again trim it. But as long as there is no complaint from the patient, there is no need to check the thread. And if there is a doubt as to the IUCD being in situ or not, do a POCUS, point of care ultrasound. So when we have that tool available, it is fine. Even otherwise, suppose we don't have an ultrasound, we can reassure her because she has not noticed the device coming out. You just tell her to report very early if she misses a period or she has any other menstrual problem. That's all that is required. Okay, so let us not make thread an issue. The second question, does Dr. Bishu Jyoti or anybody else want to comment on the LNG-IUS? Yes.
Biswajit. Yeah.
GIUS is a fantastic device because it actually helps in this kind of patients. And if this patient already has an AUB or things like that, it will actually help her. So LNG-IUS is a good device for this
I
kind
think Deepika's query is if there is no AUB, is it superior?
Actually, I think the
there is
answer
no
to this should. Can I answer, Biswajit? Yeah, you can add on to that. Copper tea is available free of cost in National Family Planning Program. So most of the patients who do not have any problem of AUB, we can always apply copper tea on that in those cases. LNG IUS, maybe some people will be asking. Otherwise, if there is no AUB, we can always go for copper tea. It's a very good spacing method. And once they do not want it or they want an issue, it can be removed. Though, and for LNG IUS, it's still expensive and they have to purchase it. Dr. Shobha, would you like to add something?
Yeah, I just wanted to add here, Dr. Seema, that LNG-IUS is fast becoming acceptable even as an immediate postpartum method because it can be used as a PP-IUCD instead of copper T. And it is so far, I think the government of India says it is category 2 if it is immediate postpartum, whereas copper T is category 1. What I am trying to say is LNG-IUS does not inhibit lactation or come in the way of lactation. So if the woman wants intracesarean, for example, if your woman says she wants Mirena instead, LNG-IUS instead of copper T, it can be done because she has had past history of menorrhagia, etc. So it can be done. It is not a contraindication. It can be done. Yeah.
Only
Dr.
thing is they
Shobha,
have to
can
buy it.
Yeah, somebody wants to add. Yeah.
Yeah, Dr. Shobha, can I just interfere, please?
Yeah.
Actually,
Yeah.
no, I have to go for my OPD. Is it possible for you to entertain the question about the CA breast case? Because it's a very short answer. I'm sorry to interrupt the flow of
Yeah,
the
sure,
event.
ma'am. We'll go ahead with the next case. Yeah.
So, madam, one thing regarding LNGIUS, I just want to say, as the bleeding is very less. Am I audible?
Yes, ma'am.
Yes, we can hear.
Gradually,
That is
the
one which
bleeding
is
becomes very, very, very less, and the patient becomes amenorrheic many times. And that is the point of concern in many women to go for LNGIUS. So we have to counsel her that she should not worry if the bleeding is less, because we all know how much they bother about the bleeding. If the bleeding is not there,
they're affordable, better to give an option, ma'am. Okay.
yeah, we have to give and we have to tell her.
Yes.
Yeah,
So
thank
here comes the sixth case. A 39-year-old has come with abnormal uterine bleeding. Ultrasound shows multiple fibroids and a submucous fibroid of 2 into 3 centimeter, which comes under FIGO 1, which is distorting the uterine cavity. But somehow she does not want surgical option, including hysteroscopic removal. But she also wants contraceptive method as a spacing method. So what do you prefer? Vinita ma'am? Vinita ma'am, is she here? I think, sorry, I think I wanted to go to the next case. I think by mistake, Dr. Bharti requested me to read one more,
No,
this
I'm
Geeta.
Dr.
Yeah, sorry.
Dr. Geeta, the
Sorry.
one with the
Yeah,
breast
sorry, Dr.
cancer.
Geeta. Sorry for that confusion. So I'll
No,
do
no,
one thing.
Radhika,
I'll
please.
just read out this case. Yeah, 37. We'll go ahead, we'll go back to the next, previous one later. 37-year-old with a BMI of 34. She's on the obese side. All the normal vaginal deliveries. And this was a twin pregnancy that was 9 years back. Both twins are alive and healthy. She gives history of right-sided mastectomy for a carcinoma of breast. No recurrence currently. And she's operated 2 years back. She's on currently tamoxifen treatment. She seeks contraception. What should be done, ma'am?
So, Dr. Radhika, very short answer to that question. Looking at her weight, her BMI is 34. She's obese and she's had a CA breast. Now, I don't know whether that was a hormone positive or negative, but let's assume it was a hormone positive. So, all the hormones are out straight away. So, I think an intrauterine contraceptive advice would be a good choice for this lady. And especially, if it is a hormone sensitive, if it's a ERPR positive tumor, a copper IUCD as per WHO MEC wheel would be a good choice, and not to offer her any of the pills, patches, rings, implants, etc., because of the nature of the breast cancer. So that will be my short answer. I mean, of course, we can go
Doing
on.
sterilization.
Yeah, but she may not want it. Sterilization would be the safest and the best. But we have to, again, as I said, counsel, and we've been discussing counseling since the morning. So we have to be aware in these patients about various issues about obesity, stroke, DVT, etc. All these things we have to be cautious in this patient about the breast cancer survivors. And secondly, she's on tamoxifen. So we would, then that causes a subendometrial edema always. Whenever they go for ultrasound, they are told, oh my God, your endometrium is thick, or your, you might have a malignancy in the uterus. So I think all the more reason we have to counsel them about the need for subendometrial edema, person to be knowing that there is a subendometrial edema. And number two, a copper IUCD, if she wants, would be the best choice. However, sterilization would be the best for her. Thank you so much.
Thank you, ma'am.
Dr. Shobha, I would like you to comment on this. Like many a times, if women is having some problem and sterilization is needed, especially heart disease, or in this case, as we can see, she is a breast cancer survivor, and many a times we ask her that husband should have a vasectomy. So what do you say about it? Like what I noticed that in few patients we asked husband to undergo vasectomy, and they did undergo vasectomy, and wives died, and later on they remarried, and there was a lot of issue. So what do you say about it? Like who should have sterilization if it is needed?
Actually, it's a very delicate subject and a very, sensitive subject, actually. So one has
Yeah.
to see the patient's, feelings, her husband's feelings, and the whole family's take on it, because here is a cancer survivor. For them, cancer is a death warrant. So we have to be very, very gentle in our counseling and very, very understanding, and then take a call. And especially if it is one of those rare cancers, sarcomas, phylloides, which have got very poor prognosis, very little interval survival, then in those cases, I think let them enjoy their life, whatever it is, and use barrier methods, if at all, with a contraceptive sponge. That will sort of not take away from their, sexual life, and yet give them protection. So barrier methods in this case may be a, option, especially if they are not keen for anything else. But be very sensitive in your counseling. That is important.
True, ma'am. Thank you for the message.
Very nice. Dr. Geeta, but don't leave us and go. You are making it so interesting.
Yeah, actually, I'll be driving to my OPD, so we are on.
Okay, that's
We are
fine.
on, but I may not be able to respond so quickly. But definitely, I'm really enjoying myself.
Okay, that's very good. Fine. Okay.
Vinita, ma'am, are you here? Dr. Vinita? Okay, I'll read out the question again, case scenario. I request any one of the panelists to answer this. 39-year-old with abnormal uterine bleeding. She has this ultrasound showing a submucous fibroid FIGO category 1. FIGO, okay? So, but she's not willing for surgical option. But she wants method for contraception also. So what is the method which is preferable for her? Yes.
We can have discussion on this, as this lady is having a submucous fibroid. Hormonal low dose hormonal contraceptive pill can be given to her, but with submucous fibroid, many a times they don't respond, and they continue to have either menorrhagia or irregular bleeding. Spotting continues because of the location of this myoma. So we can give a trial of low dose combined oral contraceptive, or in this case, and if she responds, well and good, and if she does not respond, I think she will need a removal of that fibroid through hysteroscope, and then we can further give her it. Because definitely, matlab, koi aisa there will not
counseling,
be a
yes, we have to counsel that surgical option is the best for that because of the submucous fibroid. And but however, as currently she is not willing for that option, so we can give her the hormonal method of contraception for the control of the blood loss, AUB, or even the tranexamic acid can be given. But definitely we need to counsel her that it may or may not be completely effective. That counseling has to be clearly done. Yes, ma'am. So, yes, ma'am.
The next question for you, Bharti. 31-year-old commercial sex worker using barrier contraceptive, keen on effective contraception to prevent pregnancy, and gives history of PID, which has been treated 5 years back. She had episode of PID. So we always talk of dual contraception in these cases. So what do you say about, what all methods can be given to her?
Yeah, we can advise her, because the PID has been treated 5 years ago, and at present I don't see she is having any complaints like pain in abdomen, discharge, or anything related to pelvic inflammation, suggesting inflammation. So we can very well give her the options of COC. Then we can give her injectables. We can advise her about copper T, but IUCD, but with a word of caution, because again it may she may have to face for the pelvic inflammatory disease again. So the best way is COCs. What I would suggest is
right. I think very rightly said by Bharti. We can take up the next problem.
Yes, ma'am. So generally we assume that PID, we don't put IUCD, but it is not so. Past history, well treated, we can continue to give her IUCD method also. Yes, ma'am. So this one we discuss now with Geeta ma'am. Yeah. Seema ma'am.
Yeah. So 30-year-old Para 2, Life 2 wants spacing method as contraception, and she has history of migraine headache with aura and on sumatriptan. So what should be done, Dr. Aarti?
Yeah, ma'am, the patient has aura and she is on treatment. So I will avoid combined hormonal contraceptives for her, COCs. Rest, I can offer her about IUCDs, both copper and LNG IUS, even only progesterone containing pills or implants or injections also work for her. It is up to her what she wants to, but I will not give her estrogen.
Yeah, very rightly said. Can we go on to the next case?
Yes, ma'am. So a 23-year-old, she's planning to get married and she has voluntarily come to the OPD seeking contraception. She gives history of blood disorder and reveals when we checked her record, shows that there is a history of sickle cell anemia. Currently, she's not on any medications for sickling. So what should be offered for her?
Thank you, Dr. Radhika. For her, I think the best would be a progesterone oral pill because that is one of the things that we can go by, or she can have an LNG IUS if she wants. And of course, the CHC will be the next one that we can prefer, the second choice. But the first choice will be our progesterone only preparations, implants, and of course, the LNG IUS.
Yes, sir. Thank you, sir. So it is actually very few studies have also shown that sickling episodes are lesser with progesterone treatment when the patients are on progesterone. Yes. So progesterone treatment is definitely preferred. Of course, combined hormonal methods also can be given to her without any contraindication. Thank you, sir.
Thank you.
So we'll
Radhika, I think you go with
contraception quiz.
Yeah.
So I request any one of the panelists or even together also you can answer. So it's
Even
going to be
in
just
chat
a rapid fire round.
In chat box, participant can also give an answer.
Yeah, sure, ma'am. Yes, that can be done. So this is only just a short, just like a rapid fire, I have added few points. So woman wants to use today's sponge, okay, barrier method. All are absolute contraindications except that is where she can use, okay, allergy to spermicide, recurrent urinary tract infection, multiple sexual partners, history of toxic shock syndrome. Can anyone put in the chat box also?
The different answers are coming. Somebody
So I'm
said
asking
C,
where it can be
somebody
used.
said D. Yeah. Multiple sex partner.
Is not a contraindication.
Yeah,
Yes, ma'am.
most of them, they answered this. Right.
So insertion of IUCD is not recommended in which of the following condition? Sorry. A woman having past history of ectopic pregnancy, woman having purulent discharge, discharge from the cervix, woman who is nulliparous, all of the above.
Second one, having pus-like discharge.
Yes, ma'am.
I think this particular question will merit a small amount of discussion of maybe 30-40 seconds. Is that myth which prevents practitioners from inserting IUCDs for nulliparous women, especially if they are unmarried, you know. LNG IUS actually is probably the best contraceptive for a youth, for a young woman who is unmarried but is having a live-in relationship. A LARC method like LNG IUS may be very good, or even a copper IUCD. So IUCD does not have to do anything with parity or with the status of being married. It can be provided very freely. So that is the
Even with
message
the
here.
history of prior ectopic
Dr.
pregnancy.
Shobha, hello,
Yeah.
Dr. Shobha, I couldn't agree with you more. You have taken words out of my mouth. I myself have got two young girls, severe endometriosis. What we did, unmarried, we did the chocolate cystectomy, and I put the Mirena, and they are so happy. Still single, not in a relationship, but
Not
took
single.
permission from the parents. They
Yeah.
are beautiful. The Mirena is we've removed the chocolate cyst and put a Mirena.
Yeah.
So I think I couldn't agree with you more.
You know, I respect couples a lot when they follow contraception. They are not married, but they are faithful to each other and they're not having children. because marriage becomes redundant when they are having such a strong relationship. Now,
Absolutely.
one thing I just wanted to bring to notice is one of my dear friends, Dr. Malini, is here, and I think Radhika also.
She's my HOD, ma'am. Yes,
Yeah,
ma'am.
yeah, yeah. So, Malini, you can unmute and also participate whenever you feel. We have a couple of more questions. We welcome you to join the discussion because she's consistently putting all the wonderful messages. Thank
I'm
you,
just,
Malini.
just
Yeah.
putting
Can
my
you?
comments, that's all.
Yeah,
People
that's
are
wonderful.
answering very well, and
Yeah,
I'm not
that's what.
interfering with
It's
them.
quite exciting.
Yeah.
Seema, just
Yes.
one input on the slide on the PID. Can we have that slide, that case? And you back there, but I just wanted to make one thing clear because Radhika correctly said, no,
Yeah.
the PID case, the
Yeah.
MEC
Case
criteria,
scenario. Okay. Yes, ma'am. Yes, ma'am.
the MEC
Yeah.
criteria which you showed, everything you showed very, very well. But only one thing was in the mind of the practitioner, whenever there is, a PID, they feel very afraid about putting a copper IUCD, but the woman may want only that. You put the MEC criteria. Yeah. So I wanted practitioners to understand about initiation and continuation. All right. So if there is a current PID, but the woman is already having a copper IUCD in place, there is no recommendation to remove it. You just
Remove
have
it.
to treat the PID. And after she kind of settles with the infection, she can just continue with the IUCD. There is no need to remove. But
Yes.
you cannot initiate the method.
Yes,
And this
ma'am.
is again contrary to what we were taught initially, because this is the power of evidence. It will change. It will change direction. It will change the guideline for our practice. So please remember, already having an IUCD in place, manifesting with a PID, no need to remove, just treat the infection. But if she is having PID, do not initiate IUCD. There are other methods which are good. I just wanted to tell you that. And it also holds good for lower genital tract infection, that is cervicitis. It holds the same.
Yes,
It is
ma'am.
the same. So always focus on treating the infection, because if you remove the contraceptive which she is using, she may become pregnant after the infection goes away and the inflammation settles. She can become pregnant, unwanted pregnancy. So
And
let that not happen. Yeah.
And Dr. Shobha, may I add, many times we have a copper T IUCD user on a regular pap smear and it comes actinomyces. Please do not remove the copper T. You treat her with a long course of amoxicillin.
Correct.
Don't remove
Very
the
good.
copper T.
Wonderful input,
Actinomyces.
Geeta. Wonderful input by you. So
Thank you.
let gynecologists not be afraid of infection. Let them be afraid of unwanted pregnancy. Yeah. Go ahead. Yes.
So next question is, if the IUCD is tarnished, that is, it has become black color. Okay, the copper looks like black, but IUCD is still an intact and undamaged packet. Which of the following action is correct? If the expiry date on the packet is still not passed, we can insert the IUCD. Next option is send the packet back to the manufacturing company. Do not use the IUCD as it might harm the woman. Report the incident to the district officials.
First one.
There are postgraduate who have joined and they are answering. I can see Anand Lakshmi answering it, so let them answer. Give them some time so that they are also.
Okay.
Now, panelists will not speak anything. They know everything. And I'm really liking postgraduates. They are answering it. Very nice. Good.
So tarnishing will not change the efficacy. It is the packet should be intact. So that is the one message which should be carried out. So what is the dosage of centchromon? Okay. So we call it as a chaya pill. So whether once a week, it's also called as weekly pill. So what is the dosage? Once a week, twice a week, once a week for the first 3 months, followed by twice a week from the 4th month onwards, or twice a week for the first 3 months, followed by once a week from the 4th month onwards.
So most of them, they have answered. I can see that. Okay.
So, yes, ma'am. So dosage is initially twice a week for 3 months, followed by once a week. Weekly pill is only after the 3 months over. So some women will discontinue hormonal contraception between the partners, and some physicians also advise a washout. That is, they have been taking OCPs for 5 years, combined oral contraceptive pills. They say give 1 year break and then restart. So is it really advised, or why should this be discouraged? Okay, that washout of hormones, should it be encouraged or discouraged? Venous thromboembolism risk is increased with repeated restarting. Women may not accurately predict when they will become sexually active. Stopping of the combined oral contraceptive methods for a month and restarting is ineffective at treating the side effects, all of the above. Why should this be discouraged?
Almost everybody is giving the right answer. Yeah.
So all of the above, yes. And very important thing to remember is generally we think that after taking oral contraceptive pills for longer time, they are at a risk of thromboembolism. It is not true. Many people who are presented with venous thromboembolism do so within 1 or 2 months of starting the OCP pills.
Or
So
at least a
patients are
year.
being,
Or at
yeah,
least majority will be within the year.
Yeah. It will never be usually restarting after a long period. So that thinking that washout is required is not correct. That hormones are getting collected inside the body is not correct. It's a myth.
So that is the reason the pill is required every day to be effective, because
Yes, ma'am.
whatever
It's
the
metabolite.
woman consumes gets washed out within 24 hours. Yeah.
So when faced with an obese client who requests mini-lap tubectomy under local anesthesia, the operating doctor should plan to use more assistants during the procedure because she's obese. Plan the procedure at a facility where general anesthesia and laparotomy can be performed. Suggest that the client to lose weight and ask her to return in 3 months. Use a vertical incision instead of an horizontal incision. So obesity comes under caution. It is not easily acceptable. It should be done at a center. Okay, so it should be, we should use caution for obese patients.
You put the answer.
And has answered well.
Yeah.
Yes, ma'am. So it should be done at a center where general anesthesia and laparotomy can be performed. It
Yeah.
is not ideal to perform under local anesthesia.
Yeah, Radhika, somebody opted for the answer where she's sent back with the direction to lose weight and come. Yeah. Which is not very out of place. Yeah. But meanwhile, she should be given some contraception.
So any patient who comes for a contraception should not be denied their rights. It
Yeah,
comes
she
as
should
part of
come
the
for a
reproductive right.
contraception.
So,
She should be given otherwise she'll come back with a pregnancy.
Yes.
And then you have to do MTP and tubectomy. So it's better
Maybe
to.
you can give temporary contraception and ask them to come. But here we are giving more importance to their reproductive rights. She has come for sterilization. So perform sterilization, but at a caution, with caution, taking all the cautions. So which of the following is the most accurate according to the guidelines of guidelines on emergency contraception by ACOG? So levonorgestrel emergency contraception should be avoided in women who wish to later become pregnant due to increased risk of subsequent ectopic pregnancy. Oral emergency contraception may be used more than once, even within the same menstrual cycle. A pregnancy test is recommended prior to the administration of emergency contraception to avoid unnecessary use. Most emergency contraceptives are ineffective 48 hours after the sexual intercourse and should only be offered within 72 hours. So which is the correct sentence in this? Shall I put the right answer now? I'm not.
Yeah, please.
See, okay. The first oral emergency contraception may be used more than once. That is the correct answer. Okay, the first one, there is no increased risk of ectopic pregnancy with EC. So that is not correct. Okay, pregnancy test is definitely not recommended for emergency contraception. It is actually a post-coital contraception. So it is not recommended. It's not required. Okay, so most of the pills, including ulipristal, can be used up to 5 days. So this sentence is also not correct. So what is correct is actually we can use. It can be used for more than once. Of course, it is post-coital contraception. Better to use a definitive method of contraception. But if the woman wants, she can use more than once in the same menstrual cycle. That can be done. Okay, informed written consent is required for all of the following as per the NHM guideline: combined oral contraceptive pill, progesterone only pill, EC pill, injection DMPA, Centromon, IUCD, all of the above, none of the above.
I think Upma Jaiswal has given the right answer.
Yeah.
Okay.
Does Malini want to come in? Can we have an expert comment from Malini if she's still there?
Yeah, definitely it is none of the above.
Hmm.
See, it is only oral consent, like no written consent as such for temporary methods.
Correct.
Yeah.
Very rightly put. It's only for
Yes.
sterilization that we require consent.
Yes, written
For
consent.
spacing methods, we do not require.
It's
Yeah,
just,
thank you,
yeah,
Malini.
counseling and
Ma'am, even for implants, we are taking
Yeah,
consent.
see, who is speaking? Aarti, is it?
Yes, ma'am.
Yeah. So this doubt is always there whenever we do training for implant. Many practitioners ask, please remember that in the government setup, there is no mandatory consent. But if it is being provided under some kind of a clinical trial, and you want some, research outcome out of it, maybe for the documentation or maybe to get ethical committee clearance, you will take a consent. So it is much in the private sector, it is institution protocol. So institution protocol says that you should take consent for LNG IUS also, copper IUCD also. So same way it can be done for implant also. But please remember that all these methods are voluntary methods. Actually speaking, it should come as a demand generation and the patient should demand this, that, give me this method. So that is why the concept of taking a legal consent does not exist, because we believe that contraception is a voluntary acceptance by choice, by the patient. So that is why it is none of the above. Okay.
So, but as a good clinical practice, and as you mentioned, as a hospital protocol, it can be taken, ma'am. We also take for IUCD and Implanon insertion that implant. But as per the NHM, it is not required. But I
Not
think
required.
continuously, yes, ma'am.
Not required. Yeah. No, let people not be sensitive about the legal implications.
Legal implications.
Yeah, there's no legal implications as long as good counseling is done. If you want to have a consent, then go ahead and have it. Not a problem. Yeah.
Yes, ma'am. So, to minimize the complications during laparoscopic tubal occlusion, LTO, the operating doctor should remember that this is as per the guideline I have put. The client must not be placed in a Trendelenburg position greater than 15 degrees. Pneumoperitoneum must not exceed 2 liters of air. Electrocautery should not be used for tubal ligation, all of the above. So, which is correct out of all this?
Everyone has given the correct answer already.
Yes.
Okay.
All of the above. So just remember that guideline mentioned 2 liters of air also. There are times when people prolong it for longer time, but this is as per the standard guidelines.
It's very encouraging. Yes.
So how many ejaculations does it take generally?
Just go back, Radhika. Just go back. You can actually reason it out, Whenever we conduct quiz, even if they are giving the right answer, you must reason it out. So everyone, whoever did not give also benefits, because this is more about learning than checking whether one knows, right?
Yes, ma'am. So whatever NHM guideline has given, it is actually for the minimum prerequisite. Yes, this is the standard recommendation. But there are times we generally say, when whenever laparoscopy is being done, almost patient's head will be touching the surgeon's feet. It will be so much of head low. That is what is preferred for other TLH and hysterectomy, but it's not so much recommended, because some of the places it is actually being done under local anesthesia and sedation. So with giving so much of head low, breathing may be hampered. So unless you have an anesthetist, better not to give so much of Trendelenburg. Okay, ideally it is not recommended, but maybe in a very difficult situation, you can do it, but with an expert advice, with an anesthetist standing by side, and with a proper anesthesia, it can be done.
Probably the category under which you are providing will change then,
Yes,
what
ma'am.
you are
It will become
discussing
caution.
here is just for,
This is
maybe
for a
A
simple,
category or
straightforward
something. Correct,
LTO.
correct. Very,
In
very
other
simple
cases, you may have
case.
to reason it out. What is the
Yeah,
reason why it was
and the moment you say it is special category, it's better done in a major theater or tertiary care or with an anesthetist, etc.
True, ma'am. Yes, ma'am. So generally, yes, uncomplicated cases, you should finish faster. Don't take too much of distension. It causes diaphragmatic irritation, and patient can have a lot of pain and all this. Okay. So, and nowadays that room air insufflator is not recommended by NHM. You have a CO2 insufflator. Earlier in the camps, they were using room air and all that.
No,
Without knowing how much of
that was
liter has been
actually
given.
very substandard practice. I'm so happy all that went away.
All that has been removed. And electrocautery is definitely not preferred. Fellow rings are preferred because this one, One thing is there is a risk of recanalization in a faster way. They're just doing a cautery and cutting in the center. So this method is not recommended.
Higher risk of ectopic, I must say. Yeah.
Yes, ma'am. That also could be there. Higher risk of failure, I think they have quoted.
Failure also.
Yes,
yeah. Okay.
So this is for a vasectomy. After how many ejaculation does it take for a man's
I hope this
tube?
is the last question, na, Radhika? We are touching 6.
Yes, ma'am. I
Exactly.
think there's one more true and false. Okay. So this is the question. Now, how can we declare that person is completely vasectomized and is mean to say completely sterile? After vasectomy.
Yeah. I think for this, no reasoning is needed. Everybody
So up
knows
to
the
16 generally,
spermatogenesis
yes.
cycle. Yeah, go ahead. Yeah.
So usually we have to do a semen test. So this one, and there's one more last slide for true and false. So age of the client for female sterilization in India. So I'll
Aarti
just
has
give
been
out
very
the answer.
quiet.
I'll just give out the answers. Okay.
Yeah. Yeah. Okay. Okay.
So it is 22 years now. It is not 20. So just check the age. Generally, many
22
patients come
to
at the age of 20,
49.
21.
Yeah.
20
Dono
to
dena chahiye.
49 for female.
Yes.
22 to
Ever
49.
married and at least one child. One year
child.
old. Yeah.
Ever married and at least one child. That is very important.
1 year. Yeah.
One. Correct. वो बहुत important है.
Yeah.
So retroverted uterus is not a contraindication for performing mini-lap tubectomy. It can be done. Okay. So cleaning of the instrument should be sterilized in boiling water. No, it is only for decontamination. Sterilization has to be, decontamination and clean instruments can be sterilized in boiling water for 20, sterilized, it will become a high-level disinfection.
Can I say something here? Because like I have been shifted from a medical college to private setting. What I see that most of the time very trained staffs are not there and they do not do a proper cleaning of instrument. Before it is sent for autoclaving, I think as a practitioner, we should check the instrument that they are cleaned well and there is no stain stuck onto that, and then only we should send.
Yes,
because this question was there, and I think it is very relevant to talk on this, that as a surgeon, we should check our instrument ourselves.
Yes, ma'am. So usually it will become high-level disinfection also, boiling water 20 minutes and this thing, Sidex solution and all. So it should be preferably by autoclaving only, sterilization. So using a small volume of 2% lignocaine will provide better anesthesia than a larger volume of 1%. Okay, so preferred solution is actually 1%. And it is better to get a larger volume so that you will be able to anesthetize all the layers of the skin when you are giving for the tubectomy. Okay, so earlier it was done under local anesthesia.
The dose is without adrenaline, it is 5 milligram per kg body weight, and with adrenaline, it is 7 milligram per kg body weight. So the time we are scared, we are not doing overdose, we should calculate the dose and then only we should give.
Yes.
Especially for local cases.
So LARC method by definition is administration is required less than once a month. It is not once in every 3 months. So even once a month when it is required also, it will be called as LARC method by definition.
Yeah, it depends on the type. Which category LARC?
LARC, yes. So mini-lap services can be provided. That is tubectomy. Open tubectomy services can be provided even by the trained MBBS doctor with 3 years of service, 3 years of experience.
Yeah. And for laparoscopic ligation, DGO or MD?
Yes, ma'am. With training. Either a surgeon, DGO, or postgraduate degree. Either a surgeon or gynecologist.
Yeah,
because
Radhika, it is
in many cases,
correct.
what we see that they have the degree, but they do not have training. So without training of laparoscopic ligation, they cannot perform.
Yeah, Seema, I just wanted to add here, Seema and Radhika, just wanted to add for everybody that empanelment is also needed along with training. Because if there is empanelment, then the indemnity, clause will be applicable, and for the doctors, and the incentive clause for the client will be applicable. Unless we have empanelment, we are not protected and we are not covered by the government in any way. So empanelment is a wise thing to do. Please understand that the government of India has the most robust family planning program in the world. And that is why everybody wonders why we are 144 crores still. And that is because Indian fertility is so high.
Yes, ma'am.
So that is the reason. So please, so when there is a robust national program on, it will be very wise for all practitioners to come under the umbrella of that national program for sterilization. Other things, spacing you can do on your own, but for sterilization, vasectomy and tubectomy, it's better to come under the government's umbrella and see that you get empaneled. So both the center and the surgeon has to be empaneled. Okay, thank you
Ma'am,
for that.
the CMO registration doesn't empower us with the empanelment.
Probably yes. If you are working in a government sector, then your
CMO registration. No, ma'am. In
correct.
private sector, CMO registration is done on yearly basis. Does if a gynecologist center is registered as a registered center of that district, doesn't it empower us to
It
do?
probably does. It probably does. You
Okay.
must kindly check with the district surgeon. Because
Okay.
if it is done, then your name will be there in the list of empaneled doctors that they have. So
Ma'am,
just make sure.
yes, ma'am.
Yeah. You must check that your
Previously,
name is there. Yeah.
yes, ma'am. Previously, there was one Hosla Sajidhari program was running in our district in
Correct.
Uttar Pradesh.
Correct. Yeah.
So that time we got empaneled with that, but probably
Dr.
with time that
Malini is
program.
responding, no, you have to get empaneled. That does not cover.
Okay.
Obviously,
Okay,
she
ma'am.
knows more because she
Every
has
time
served in
surgeon changes,
public.
even the hospital is recognized. The surgeon changes, they also have to register their name with the district hospital, district health officer with the center.
Radhika, stop sharing the screen, beta. This is enough.
Yes,
Yeah.
ma'am.
Okay, thank you, ma'am. Thank you so much.
Yeah. Stop sharing the screen. Yeah.
Did I stop? No, no.
No,
Just a
no.
minute, ma'am.
Yeah, so somebody 1 plus CPH 2381. So normal
Madam, can
gynecologists,
I
we are
leave?
all normal only.
Shobha,
Should
madam,
get
thank you
empaneled.
very much for the
Yes.
opportunity. Can I leave?
Yeah, of course.
Thank you,
Thank you,
Radhika
Bharti.
madam. Thank you, Seema madam. It was a
Thank you,
nice
Bharti.
panel
Thank
conducted.
you.
Many cases covered, so many points were taken. Thank you so much.
Yeah, that's wonderful.
Thank you,
So
Shobha ma'am,
yeah,
for including.
Wonderful.
Thank
yeah,
you so
please
much.
wait, please wait. So
And
that means that yeah, gynecologist has to get empaneled to do sterilization. Yes, your postgraduate degree in which says that you have trained for laparoscopic sterilization will not hold in good stead. Once you become a practitioner with MD on your certificate and you are registered for practice, you have to have an empanelment also. Yes. You have to have. No, Malini, can you unmute and tell? Has Malini left? Okay. Okay. Seema, your conclusion on everything and Radhika, yours. Vishwajyoti, do you want to add anything?
No, I don't want to. Thank you very much, ma'am, that we had, and thanks to Dr. Seema, ma'am, and Dr. Radhika for having me for these excellent questions, and Dr. Shobha Gudi for having me here. Thank you, madam.
Lovely. It was.
Dr. Shobha, you really answered all the queries which were difficult, like especially feeling of thread, then property, PPIUCD,
I
counseling
think
for, PPIUCD.
there is too much of myth around contraception,
Yes.
and I feel at least we should make it very clear. Yeah.
Yeah.
So, Aarti, anything more to add? We can ask them all. Nozo sir, great that you were there till the end. Nozo sir is still logged in, but I don't know. I can't see him. Okay, then I think it will be time to conclude, Nilima. Let me give the vote of thanks. Let me thank Radhika and Dr. Seema in particular. So much of enthusiasm. Thank you. And I think I feel that you are correctly positioned to, have more academics in your daily routine and help us out more now because you are not on your toes as you were the last year. Hai na? Maybe you will have more time for reading and coming across. Thank you, Radhika. Lot of effort, as she said, and also Vishu Jyoti for being here. Aarti, such a blessing to see you. Bharti and Geeta have left, but my thanks with them. And my thanks to all the ICOG office bearers who joined today and all the past presidents who joined, making this event a successful one. And thanks to the ICOG technical team led by Nilima. Thank you so much. Thank you, Parag. I don't see you.
Thank you
I
so
don't
much,
see
ma'am.
it.
Thank you for including. Thank you.
Bye bye.
नीलिमा, पराग नहीं है ना? पराग एंड सरिता?
No, ma'am.
हाँ ठीक है, फिर तो ठीक है. Then we can conclude. Thank you. Good night, everyone. Thanks a lot.